Yeah, thank you for the question. So I think it's, when the cells that initiate graft versus host disease are the cells that are infused. And we and others have shown that naive T cells, that are T cells that are not antigen experienced, are the most potent inducers of that. That is, that their progeny will be more likely to cause graft versus host disease. There's also data that central memory T cells also have some potency to cause graft versus host disease, or less than that. But that's different than how GVHD is maintained once GVHD has already been established. And really the main insight of our work, I think, is that within a tissue, there's everything that you need to maintain a T cell response independently of the input of new T cells from blood. That is, there's antigen present in the tissues, there's antigen-presenting cells, which can mold the T cell response, and then there are the T cells themselves. And so really we had to go about formally designing experiments to formally prove that. And then the second, I think the thrust of this question is, what are the properties of those cells in the tissues that are the cells that can perpetuate GVHD and create new effector T cells that cause tissue damage? We think, and we haven't completely proven, that those cells express the transcription factor TCF1, the gene for that is TCF7, but they may come in different flavors, and they may not be a monomorphic or single population of cell in the tissue that does this. But I think we will learn about that to see whether that's the case. And then in terms of what could potentially be translational, is that your next question? But so anyway, I think that there could be different flavors of cells that have this progenitor population. It doesn't have to be confined to a single type of cell. Cells that see very intense antigen may differentiate into one type of cell, whereas cells that have less exposure to antigen or have lower avidity T cell receptors may differentiate into another type of progenitor cell. And our current data suggests that could be the case, but again, more work needs to be done. Yeah, that's a great question. So let's deal with the first part of it, is how you might inhibit those cells. I think first of all is defining the different populations that are involved, and then looking for targetable pathways. And as I mentioned in my talk already, some of these cells seem to express the IL-7 receptor. We'll have to investigate whether that's actually essential for them, and if it is, some of the therapies that we use already, like JAK inhibitors will target those. Finding things that are more selective will take time to see whether they're, if you're going to target them either by targeting their signaling pathways or by finding surface markers that allow you to delete them with antibody-based approaches. And so, we're not really there yet to know whether that's possible. Now, as for whether this is going to preserve the graft versus leukemia effect, I think once a person has grade 3 to 4 graft versus host disease, the problem is graft versus host disease. And really, it's not really compromising the graft versus leukemia effect. It's having them not die from infection in the process of treating the graft versus host disease. So I think that's actually the more important question. But if you take all T cells out, you do ablate the GVL and the immune reconstitution. So that's clearly not the direction that you want to go. But once patients have severe disease, treating the graft versus host disease is the high priority. It's going to be a very difficult question to answer in the clinic as to whether there's more relapse in these patients once you treat them. And that's because, they've already had severe graft versus host disease. And so if they've had an autoimmune response that did contribute to the eradication of leukemia cells, that may have already happened. And so it's going to be very difficult to have one group that's treated one way, one group that's treated another way, and then to really compare the rates of relapse. It could be done through registry studies, but there would probably need to be a lot of data. We do plan to, at least in part, address this in the mouse models by doing something called in vivo cytolytic T cell responses, where we would get the mice, we would delete the TCF7 positive cells, and then we would infuse into the mice potential target cells of the alloreactive T cells to see whether that activity is still preserved. But those experiments are probably at least a few years away. It's kind of a similar question too, really. And I think, again, more work needs to be done. I mean, so one thing that this question presents is whether you could prevent the development of these progenitor cells. So, for example, the cells that are so-called canonical TPEX could be, you might be able to prevent the differentiation early on. It may be different with calcineurin inhibitors, and I think there's some data from a few other groups that suggest that calcineurin inhibitors in a way protect the cells from going on one path of differentiation. But when you wean them, another type of progenitor takes over. So I think it's going to be really, really a challenge in that way. But I do think there's potential interventions to prevent the development of some of these types of T cells. But again, I think it's more likely that you're not going to subject everyone to a therapeutic strategy, but you're going to take the people who actually have severe graft versus host disease and try to test the new therapies. And those, as I mentioned, it's the identification of surface targets or signaling pathways that are relatively specific for these progenitor-like populations to see whether those will translate into a therapeutic effect. And the other way, which I did mention, is better locally applied therapies. So right now, you can treat some type of GVHD of the skin, even if it's extensions just with topical steroids. It's possible that things like topical JAK inhibitors could be relevant. There are issues with how deep you can penetrate the skin with those, and that could be a limitation. But you could potentially imagine other therapies that are locally targeted to the gut that could be preventative. So if there is a way to target small molecule inhibitors to be taken up by T cells in the lamina propria or in the epithelial layers, that would be an approach. But we have not, that will be work for other people, I think.